A very good morning, friends. And as Dr. Suvin talked about, we definitely like to thank all of you for being with us in this beautiful venue in Mumbai. And the previous course, we had such a nice discussion. And this is a continuation of a similar thinking on how to make cataract surgery much more meaningful so that we go from basics to complex cases. And you would have seen this instruction course includes the galaxy of surgeons, which are well known not only in this country, across the world, and they've been teaching entire world for so many years, and their tips will be such a handy for all of us today. I would like to invite all my co-instructor. I am Dr. Jeewan Singh Titiyal from RP Center, New Delhi. We have Dr. D. Ramamurthy. He's come. Good morning, sir. Dr. Mahipal Sajdev, I'm pretty sure he's going to join us very soon. Dr. Suben Bhattacharji, he's here only. And Dr. Abhay Basavada, he'll join subsequently. Dr. Arup Chakravarti and Dr. Partha Biswas, who has made everything possible in this horizon to make this entire scientific committee working for a betterment of entire society for so many years during the COVID time, now in our physical time also. So I will start with the first talk. Dr. Arup Chakravarti has to be in another instruction course. I'll request him to start today's this very important instruction course. And what would be better than talk about the basic aspects of surgery, which is capsular access in phaco, and that too in a compromised capsular access, how we should perform phaco to have a best outcome possible in that scenario for our patients. Dr. Arup Chakravarti, he is our editor proceedings AIOS since 2017. And you all know he's a well-known faculty across the world. His instruction course in American Academy is one of the most popular instruction courses been there in the history of AO. Dr. Arup, please.
Good morning, friends. Thank you, Professor Titiyal, for the very kind introduction. A safe and effective phacoemulsification requires an intact rhexis. However, it has been noticed that in about 0.79 to 5.5% of the situations, the rhexis is compromised. And in fact, in one article from Moorfields published in the American Journal, the incidence was 1.5%, and 1.65% of those cases went on to have a posterior capsular rent. So, it is not a very common phenomenon. In fact, I have not encountered this situation for the last 2 years, but it can happen. So if you are faced with this situation where the rhexis has gone to the periphery or it has become a runaround, so what are the options? Do you continue with phacoemulsification or do you do a safer non-phaco technique? Now, if you decide to go ahead with phacoemulsification, would you modify your technique or would you perform phaco applying the same strategy that you do for a routine case? And if everything goes on smoothly, phacoemulsification, cortex aspiration, what kind of intraocular lens do you use? Are there any considerations? So these are some of the situations I'm going to talk to you about. But before that, it is important to be aware that rhexis tear can happen at multiple stages during the cataract surgery. I'm going to talk to you about the primary rhexis tear, which I mentioned is very rare. And most of the time it happens only when you deal with a very intumescent cataract, post-vitrectomy with silicone oil in the posterior segment. I have also had the rhexis tear as a secondary event where capsular rhexis was small, the cornea was not very clear, and at certain point I damaged the rhexis margin using my chopper or maybe the phaco tip. So I'm not going to talk about that situation. There are certain risk factors where the rhexis is difficult to make, like pseudoexfoliation, white macho cataract, pediatric cataracts. So the patient has to be properly counseled, and your OT also has to be appropriately prepared in case you require the vitrectomy equipment. Now let me show you one case. This was again an intumescent cataract, and I always plan to do a two-stage rhexis, a primary small rhexis, and then aspirate the cortex. decompress the capsular bag, and then do a secondary rhexis. Here, with the cystitome, I don't have much control over the capsule, as you see here. It has an angularity, and if one is not careful, it may go to the periphery. So I switch the instruments. I take a nutrator forceps, and at that moment, the tear goes very jerkily, and it has again an angle going to the periphery. So I use Helon 5 in this situation, injected Helon 5 not at the center, in the periphery. In spite of that, rhexis ran to the periphery. So I decided to continue with phacoemulsification, but in such situations, you require a larger capsular opening because you don't want to put the rhexis tear point at additional stress during phacoemulsification. So the capsular opening is enlarged, and I also ensured that there are no redundant dog earing of the capsular flaps, because they may inadvertently get caught up during phacoemulsification or during irrigation aspiration with undue traction on the capsular zonal apparatus. So the rhexis again, has to, as I mentioned, it has to be enlarged. Some surgeon believe in putting a cut in the opposite, diametrically opposite to where the rhexis tear happened. I'm not a big fan of that strategy, but it is just, it has been tried out and it has been described in the literature. So this is what I follow, a generous capsular opening that has been done. And then these kind of situations don't require any hydrosteps. And if it is a brittle nucleus, so, and when you start phacoemulsification, spontaneous hydrodissection will happen and the nucleus can be easily rotated. So my strategy here would be to chop, because chopping is least traumatic to the capsular zonal apparatus. Before I chop, make a little scalp, go as deep as possible. Try to use a high power, because I don't want any linear movement of the nucleus when I'm using phaco with low power. So as I go to a sufficient depth, then I start chopping. While chopping, make sure that you are no longer in the capsular bag. The forces should not be transmitted to the capsular bag, to the area where the rhexis tear has happened. The nucleus is elevated a bit in the capsular bag, and all the separation maneuvers happen at a point or at an angle which is away from the rhexis tear that has happened. And again, it is a vertical chop that is happening, and the lateral separation the method has to be as atraumatic as possible. And since most of the phaco is happening at an anterior plane, the rhexis margin, or sometimes, because the rhexis is large, the capsular opening is large, some fragments may pop into the anterior chamber. So it is important to inject OVD, dispersive OVD from the side port to protect the corneal endothelium. And with the due diligence, etc., the phacoemulsification goes on pretty well. Be very gentle in all the intraocular maneuvers, like as you saw, what you saw here was rotating the nucleus was done in a very gentle manner, and chopping again was done at a little more anterior plane. At all points in time, the anterior chamber depth has to be maintained, because if it becomes shallow, then again there is more stress on the capsular tear that has happened, and it may be converted into or it may progress into a wraparound tear with a posterior capsular issue. So make sure that keep the AC deep all the time. Use a dispersive OVD, partly to fill up the anterior chamber and protect the corneal endothelium. And then what lens? So now, in this particular case, I could have used a single-piece hydrophobic acrylic lens, but I decided to use a 3-piece hydrophobic acrylic lens here because I thought, this is what the patient had opted for. But if it was a patient who required a toric lens, I would have perhaps gone ahead with the toric lens. I have heard from my friends that if the rhexis tear angle meridian coincides with that of the toric axis, they have still kept successfully a toric intraocular lens in this kind of situation. I don't have any such experience. So the haptics are kept in the sulcus, and I also attempted to, I pushed the optic behind the rhexis margin. So it was a sort of a capture that happened. Though rhexis margin is not complete, but still, it can definitely be attempted. And the surgery went pretty well. And this patient has been under follow-up for a long period of time. The lens is very well centered. This is where the rhexis margin is run to the periphery on the nasal side. So friends, I would like to conclude by saying that rhexis is paramount for safe phacoemulsification. And further management options in compromised rhexis situations depend upon a lot of issues, a lot of factors, like how experienced the surgeon is, what kind of cataract, etc., etc. Now today, if I have a very hard cataract with a compromised corneal endothelium, shallow anterior chamber, and rhexis that has run to the opposite side, nasal side, I would prefer to convert the patient from a phaco to a non-phaco situation. So for a young surgeon who is not familiar with manual small incision cataract surgery, it is okay to close the case and refer the patient out to a senior friend. If you know how to do a manual small incision cataract surgery well and good, you can always convert. Please remember, the patient is going to thank you for a good job done. Patient is not going to thank you for a brave attempt and ultimately messing up the case. So if you're performing phacoemulsification, try to do endocapsularly. If it doesn't work out, iris plane with adequate corneal protection and use an appropriate intraocular lens. So friends, a good phaco is still possible in rhexis test situations and conditions apply, which I have already discussed. Thank you so much for your kind attention.
Thank you, Arup, for showing such a wonderful video, giving such a nice surgical tips to do phaco in very, very difficult situations here. Next, I would like to invite Dr. D. Ramamurthy, who is, you all know, is a you can say, versed with the teaching the audience for so many years, and his videos are one of the most you can classical in terms of teaching wise is concerned. And he's going to talk about with us today is intermittent white cataracts. How do we manage those cases effectively? And I'd like to thank Arup for showing that difficult case scenarios. Dr. D. Ramamurthy, please.
Thank you, Professor Titiyal, for having me over here for this wonderful course. It's so nice to be back in circulation with so many faces unmasked, and really look forward to these times lasting forever. The topic given to me by Professor Titiyal is intermission cataracts. And let me start off with one typical case. This is a intermission cataract, and I first make the side port incisions at about 70 degrees from my central port. And then this is high molecular weight viscoelastic, cohesive viscoelastic that's going in. That's to essentially keep the anterior surface planar. Through the side port, I introduce a 26 gauge needle through the capsule and take out a little bit of cortical matter. This is flocculent cortex, and this is not going to come out in one single go. And as I proceed with it, there are going to be pockets of cortex that needs to be evacuated. So that's the message I want to leave behind. Sometimes it's fluid cortex which just flows out. But here, as you can see, as I proceed with my capsular rhexis in a very controlled manner, and each time I go ahead and inject cohesive viscoelastic in front of the area of the rhexis where I'm going to be performing, and those pockets of cortex is continuously being removed. So you would see that it's running into bumps of cortex, and each time before proceeding, it's a good idea to manage the intralenticular pressure by evacuating a little bit of cortex and injecting cohesive viscoelastic in front. So that's how I go ahead, and obviously you often end up getting a smaller rhexis in these situations. And as you can see over here, I'm going ahead and polishing the rim of the anterior capsule. That's a hydroimplantation of a single piece intraocular lens that's being done. That's a multifocal intraocular lens, and as you can see, many rings of this multifocal is hidden by the capsular rhexis margin. So obviously it's inadequate. So though I did a hydroimplantation, I go ahead and introduce viscoelastic, create a small nick over there at the margin of the capsular rhexis, and using a micro rhexis forceps through the side port, which does not distort the main port, doesn't allow the viscoelastic to flow out, I gently go ahead and enlarge the capsular rhexis. It's extremely important that the capsular rhexis remains on top of the optic so that you have all the advantages of the posterior capsular opacification prevention. And when I come into the subincisional area, I just go ahead and go in with my left hand, and I use the Sinskey hook to stabilize the globe and complete the enlargement of the capsular rhexis. That's completed, and I get a reasonably decent rhexis with a fairly mature cataract. Not the best of the rhexis, but I'm quite satisfied with it because there is a good overlap of the optics of the lens without any runoff. Let's look at another situation. This is a fairly old video of mine, but explains a certain concept quite nicely, in the sense that it's not over till it's completely done. And in this case of capsular rhexis, as you can see, the idea is to keep the anterior surface of the capsule totally flat. Whenever there is a bulging forward, there is a tendency for the rhexis to run off to the periphery. As you can see in this cartoon with the skier on top, when there is a bulge, there's a tendency for it to run down to the valley. So the idea is to remove cortex and inject viscoelastic, preferably cohesive viscoelastic, to keep the anterior surface as flat as possible. As you can see in this, it proceeds in a methodical manner, but in the last bit, I lose patience, and there is escape of viscoelastic through the main port because I'm using Utrata forceps, and you have the rexis running off into the periphery. So being aware of this and continuously keeping the anterior capsule flat is extremely important to achieve optimal results. Coming to a situation of pediatric cataract with the intumescence, obviously it's a double whammy in the sense that you have all the problems of a pediatric cataract, a very elastic capsule, at the same time a bulging anterior capsule. In these cases, extremely important, you do not only aim at a small rexis. As you can see, I proceed in a very methodical manner in small bits of rexis being done each time, but the pull is not only towards the center, but also towards the apex of the cornea. And basically, I'm just emphasizing on making a capsular rexis in these situations simply because the rest of the removal of the cortex and the intraocular lens implant is not really very difficult. In this particular video, I'm going to emphasize on this excellent procedure of Brian-Little maneuver. Please watch as we proceed that at around 7 o'clock procedure, 7 o'clock position, there'll be a tendency for the rexis to run off. In this, the normal tendency would be to go ahead and pull the rexis along the same direction as you're proceeding. But what you need to do in this situation is to lay the rexis back on and pull on the rexis. Right now, it's just proceeding smoothly. But here is a situation where I'm going to have a tendency for the rexis not to proceed in an arcuate manner, but it starts pointing out more towards the periphery. That's the danger signal. That tells you that this rexis is going to extend. You have to immediately recognize that. And this is nearly the situation where I'm ending up. Unfortunately, the magnification is not enough for all of you to make out very clearly. But I can make out that this rexis is pointing more towards the periphery at this point. So what I do is to inject some more amount of viscoelastic in front and then go in with the Utrata forceps. And as you can see, I'm dragging it back towards the area from which the rexis came and also towards the center. This sort of rescues the rexis back on course, and I'm evacuating a little bit of cortex again. As I pointed out, some amount of cohesive viscoelastic is coming out. Then I go ahead and complete the rexis and proceed with the surgery. Maybe at the end of the case, when you see the intraocular lens, as you can see over here, this is exactly the area where the rexis tended to run off. And here what I did was to play the rexis back on flat on the surface and pull the rexis in this direction also inwards. You do not pull in this direction because then the tendency for running out will be greater. So you pull back in the direction which you came and towards the center, and this goes by the name of Brian-Little maneuver, and this helps whenever you are faced with a situation like this. Let's look at another situation, a Morgagne white cataract. This is a condition where you would feel that the lens becomes decompressed very quickly because the lenticular matter just flows out. So, but here what you are phasing out with a fairly tremulous anterior as well as a posterior capsule and a hard nut of a nucleus. And obviously here there is because of the tendency for the posterior capsule to trampoline, and you do not get a good hold on this nucleus. Sometimes there is risk of damaging the posterior capsule. In these situations, it's a good idea to even inject the intraocular lens into the capsular bag, as I did just now. That acts as a scaffold, and using adequate amount of dispersive viscoelastic to protect the endothelium, you go point out your phacoprobe as posteriorly as possible, go ahead and complete the surgery, and this is one way of protecting the posterior capsule in these situations. Triple rexis, this is just the way you can manage the rexis. Arup also showed something like this, and as you can see, an initial nick is made. A small, as far as you get a complete round rexis or it's arcuate, the tendency for it to extend is not there. So that's a very small rexis that has been made. And now I'm evacuating the cortex. Mind you, the flocculant cortex is not just in front of the lens, but it's also behind the lens. So you decompress, slightly enlarge, and then go ahead with the removal of the lens material, the nucleus material, chopping, because these are fairly easy to crack. And once before the intraocular lens implantation, I often prefer to do it after the intraocular implantation. You can do a third time enlargement of the rexis so that the rexis that you finally end up with is about 5.5 millimeters or so. It's often said that it's a boom to have a LRCS platform, but I would just like to point out a couple of problems I face. It's most often a situation like this, a Rexis that has been made. You stain these capsules on the table just because you want to know where exactly the capsule is. And most often you are pleasantly surprised to see, as in this situation, it's a free-floating Rexis. You don't even have to take the care to remove it, but as you introduce the phaco probe, it just moves in. But it's not always a condition like this. You can see another intumescent cataract with the lens bulging forward into the anterior chamber. And here again, I go ahead and use a capsular Rexis, the LRCS platform. The Rexis is made in just about 1.2 seconds. I thought I'll have a complete Rexis, but as you can see, the Rexis in this case is completely disrupted. Just the initial gush of the cortical material from the capsular bag disrupts the capsule. So observing all the principles that was enumerated in the earlier talk, we have to go ahead and do the surgery. And because flaps of Rexis were still available, I could go ahead and place a multifocal intraocular lens between these flaps. Please concentrate in this particular area. In this case, it's a capsular Rexis that has been made, but you can see there is a skip over here, and you have to identify that area. Obviously, the capsular Rexis is not complete over there. If you just pull on the this case in a down-up maneuver, there will be a Rexis runoff. So essentially, what I do is to circumvent that area. So as you can see over here, there's something like a bulge over here. That's because that's where I took my Rexis around the skip area, which had been left behind with my laser. Now, what if at all there is a Rexis runoff? Obviously, in these cases, most often, depending on your experience, you can go ahead and still do a phacoemulsification. Last of my videos, Dr. Titiyal. And what I do is to just cut off the redundant piece of cortex. In these situations, I like to do a stop and chop maneuver, where in a very controlled manner, losing low parameters, I create a central trench. And then I rotate it by 180 degrees so that the direction of my splitting of the nucleus, as you can see over here, I don't even use the phaco probe. I use two different Sinskey hooks with deep grooves, go into the depth of the groove and cut them into two heminucleus. We are not stressing the area where the Rexis ran off, and subsequently do most of my phacoemulsification. Most often these are soft cataracts, bring them into the anterior chamber, and with adequate cover of dispersive viscoelastic, go ahead and remove the nucleus using short bursts of energy. As you can see, the amount of energy that I'm using is quite minimal, and an intraocular lens implantation is still possible. Having systems like active sentry, etc., adds to the safety features. Thank you so much for your kind attention.
Thank you, Dr. Ramamurthy. We know that these are one of the most wonderful videos which can be seen, and the tips he gave us how to come out with those difficult situations, how to handle those intumescent raised intralenticular pressure cases by doing capsular Rexis in those cases. Even you have a runaway capsulotomy, capsular Rexis, how you manage these cases, wonderfully shown. Thank you, Dr. Ramamurthy, sir. Wonderful teaching here. We now invite Dr. Subin Bhattacharya. You just heard his entire course on small pupil management. We'd like to hear some more tips from him, how to handle these cases with various devices.
Thank
Dr.
you.
Subin.
Thank you, Professor Titiyal, sir. It's a privilege and honor to be in your course year after year. I'm Subin Bhattacharya. I'll be talking about dealing with the small people, and I do have a financial interest in the BHEX, and there will be a significant overlap between the last talk and this, because you can't take BHEX out of small people and small people out of BHEX. So dealing with the small people is all about anticipation, identification, and management. So when the pupil is reduced, size is reduced to half, it's a little bit of geometry, simple geometry, school elementary geometry. When the pupil size is reduced to half, the surgeon's viewing area is reduced to a quarter. If the surgeon can't see the cataract well, he can't operate safely. And that is a serious disaster. So you need to ask yourselves, what would you prefer? We've all burnt our fingers. We're all great surgeons. We've burnt our fingers trying to do small people's phacosurgery without devices and taking a call a little late or not taking that call. Now, if you are undergoing a cataract surgery and you have a 4mm non-dilating pupil, what would you like your surgeon to do? Use a pupil device or use the skills alone? Rest, I think you have the answer. So can pre-op pupil size be an indicator of possible IFIS or not? This paper published quite some time back in 2011. The conclusion was that for a pupil 7 millimeter or small, the risk of IFIS existed regardless of alpha blockers. So tamsulosin is not the only issue. And that is the long list of drugs which can cause IFIS, including common conditions like hypertension. I mean, every patient, if not, every alternate patient has hypertension. So no amount of history taking can prevent surprises. And intraoperative meiosis is unpredictable. Let's come to terms with that. The good news is that more and more surgeons have reduced their threshold for using a device because of the unpredictability of IFIS and the exacting patient expectations. It's a litigious society now. And we do know that premium IOLs can be very unforgiving. So you don't want to take chances. So I believe that a disciplined approach is very much required when you come to small pupils, whether you're using iris hooks or pupil expander, doesn't matter. Treat every eye as a potential IFIS candidate. Reduce your threshold. Please have a stock of devices in your OR or operation theater. We must know how much viscoelastic and where to inject it. We need to distinguish the elastic from the non-elastic rigid pupil, and you need to have a handle on how much pupil size you really require. It's bigger is not always better. And the choice of pupil device will very much depend upon whether you use OVD alone or iris hooks or pupil expanders, the elasticity of the pupil, and how you wish to tear the rigid pupil. IFIS, actually, no device will work. I'll tell you about that. So now, injecting viscoelastic to inflate the anterior chamber and expand the pupil is a very bad idea because you're plastering the iris to the lens surface and leaving no space for the pupil device. So inject viscoelastic there under the pupil margin and keep the anterior chamber shallow so that you lift off that pupil margin a little bit to facilitate placement of the pupil expansion device. So keep the anterior chamber shallow. Overfilling of the AC is counterproductive. Use viscoelastic under the pupil margin. This paper by Chang and Campbell in 2005 told us about IFIS, and it said that unlike the non-elastic meiotic pupils, the IFIS pupil immediately snaps back to its original size following attempts to stretch it. So small pupils are of two types, elastic or non-elastic. The elastic pupil is like a rubber band. You can stretch it. Any pupil expander will work. The rigid pupil is very much like a string. It's not going to stretch. So you will need to tear it. What you use to tear it is up to you, whether you use a bulky expander like the Mulligan ring or the I ring or an APX or the BHEX, or use Kugelin hooks and then use a delicate device like the BHEX. So you could check the elasticity of the pupil before you start out the case. As soon as you've done your paracentesis, inject BSS or Englactate to the side port. If that pupil expands momentarily, you know that it is an elastic pupil. You really don't need to bother too much. But if that pupil does not expand and it doesn't budge actually, then you know you're dealing with a rigid pupil. It's a fibrous pupil. You need to stretch it with 2 Kugelin hooks. Again, it's your choice. 2 Kugelin hooks, I believe, gives you a very controlled. You don't need to stretch limbus to limbus, and you have a good cosmetic effect at the end of the day. You have control. You have a handle on the pupil size. So mechanical dilatation of the pupil in IFIS, it's no good. If you have rigid fibrotic pupil, yes, it's effective to facilitate probably use of a device, or you can, if you think that stretch is good enough and this pupil is not going to come down, so pretty good, go ahead. So we have iris hooks and retractors we've been using for a very long time, and we have the pupil rings like the Mulligan ring or the BX pupil expander now. Now, I have not used the iris hooks for many, many years now for obvious reasons, but I'll pull out a video from my archives and I'll try to show you a few steps. So I like to do the side ports first, the 3 and 9 o'clock when I'm using a superior incision. I'm sorry, I'll keep. So, and visco from, sorry. I'll let it run. What's the matter? It's hanging. I'll start again. I'll come to that slide. I'll come to that slide, don't worry. I'll let that video run without any interruptions so that we don't have a mess. Yeah, so, yeah, I'll do that. Okay. Go to duplicate sites. Okay. Again, the same problem. Okay, So I'll not touch this video now. So I make the side force first, and I don't want to overfill. And the paracentre is in a clear corneal incision. I leave I leave a small conjunctival mark. Otherwise, it's very embarrassing. You can't find your paracentesis. That's when I used to do the iris hooks. And I like to make sure that the stopper is well retracted. Otherwise, it's again embarrassing. You've gone halfway through inside, and then you realize that the stopper is not pulled back. So pull back the stopper. Do not try to. This is an overstretch. This is an overstretch. This was in the times when I used to do the iris hooks, and I place the phaco incision much later. Please keep a control on your capsular exercise. Don't get carried away by the size of the pupil expansion. Remember that the pupil margin is now little anterior at the limbal plane, and it is often antiflexed. So every instrument that goes into the eye has to circumvent that kind of antiflexed and elevated pupil margin. For removal, you can just hold that stopper, put it back, push that device inside, and just pull it out. It momentarily stretches. You really don't have to do any heroics of turning and twisting. Just need to, that nylon hook will just kind of, or polypropylene hook will just straighten for momentarily. Now, iris hooks do have a downside. I'm not anti-iris hooks, but these are genuine downsides which I found. So multiple corneal incisions, yes, theoretically the risk of infection is high. We do have iris sphincter tears, and I believe that in a square pupil, the corners are wasted space. We are going to work within the rexus, so why do you need the corners? The anterior chamber gets cramped because your pupil margin has been elevated to the limbal plane. So you are a little struck for space, and that could lead to iris trauma and corneal endothelial damage. And this publication in 2019 in the JCRS suggested that iris hooks do take a longer time than pupil expanders, 14 minutes for consultants more, and 24 minutes for trainees. And of course, we could have a permanently dilated pupil, which could be very annoying for multifocal patients, and of course, cosmetic issues. So we come to pupil expanders like the BHEX. It's a thin device. It's got flanges, notches, and it's got tabs for holding. It's very thin, 75 microns, and as thin as a human hair. Simple design, user-friendly, tissue-safe, affordable too. What's important is that the housing is transparent so that you can hold it with the BHEX 23 gauge forceps, and entire travel, you can see the device through the entire travel. It's never kind of invisible, so you know what the device is doing. Unlike when you're using an injector, you don't know whether the device is twisting, turning, somersaulting inside the injector. The most important difference between the BHEX and any device pupil expander that's been there in the past is all the devices were biplanar. So this is the device and this is the pupil margin. Whereas the BHEX, the device is in the single plane, it's super thin, and the iris margin, the pupil margin kind of bends at the notches. The pupil margin straddles the notches, and that kind of lets us obviate that injector. How big do you want the pupil to be? If you are assured that you're going to have a 5.5 pupil which is not going to come down on you, what's important is the coming down, not the size of the pupil. All of us are experts at doing surgery with 5.5 pupils, and the BX allows you to do that. If you're using iris hooks, I would strongly encourage you not to go beyond a 5.5 and keep a handle on that. Now, this is a rigid pupil. I just showed it earlier. Rigid pupil pseudoexfoliation, Dr. Deepak Megur, little bit of viscoelastic under the pupil margin, and that's a 5.5 pupil, nothing more than that. And this is a pretty hard cataract. All you need to do is chop that nucleus into small fragments, and you are pretty comfortable getting away with whatever technique you use. You need to just get that into smaller fragments, and thereafter it's an easy job. IFIS. Now, all of us have our own personal preferences. Most of us would say, I would prefer iris hooks. Some people will swear by the Mulligan ring. Others would swear by the BHEX. Actually, for me, IFIS, there are two components. Meiosis, iris hooks or pupil expanders provide a constant pupil size, good visibility, safe phaco, nothing more than that. Iris prolapse, no device works. It's the severity of the IFIS that day, that eye, which matters. Whether you're using hooks, pupil expanders, anything. It's that day, that eye, how bad it is. So for IFIS, I would say any device which is thin and can go in and out of small incisions, whether it's iris hooks or pupil expanders, it's your choice. So that BHEX can be taken out through a 1 millimeter side port, and that's a big blessing when you're dealing with the iris prolapsing through all incisions, in main incision and side port. So intraoperative meiosis, the advantage with the BHEX is, I'll take just half a minute more, and where you can actually have instant confirmation as you tuck those flanges. You carry it to the periphery and you have instant confirmation whether you engage the capsular rexus or not, because the notches are entirely visible. With the Mulligan ring or other devices where the engaging part is on the sides, you cannot have a direct visibility whether you are engaging the capsular rexus margin or not. And this is a wonderful video which is available at the American Academy website. This is by Dr. Michael Henry on the guidance of Dr. Deepak Paul Edward in the University of Chicago in Illinois. And this is an eye with a tube shunt and a very shallow anterior neovascular glaucoma. And it was easy to use the BHEX with a single incision tucking all the flanges. That could be very helpful in complicated cases like this. So for me, the choice of device, intraop meiosis, is either iris hooks or BHEX. Anything which helps me not catch the capsular rexus margin. Choice of pupil expand and subluxated cataract, absolutely no doubt, iris hooks. I would not use my own BHEX because iris hooks allow you to use asymmetric pupil dilatation for the area where you have subluxation to give you better visibility. There's nothing like more important than visibility. I'd strongly encourage you to take a look at this tips and tricks on BHEX, which is available on our website. And this is another tips on phacoemulsification. Thank you very much for your kind attention.
Thank you very much, Sven. Wonderful, wonderful concepts and the device that you have. You make all of us very proud. Now we move on to the management of subluxated lenses, soft, hard, and you name it. And there is no better person than Professor Jeewan Titiyal. Sir, thank you.
Yeah, thank you, Abhay. And again, good morning to all our friends today. And after listening to Suvin and his instruction course in the morning, I think we are all now become expert in managing small pupil in a very, very difficult situations also. And one area which we again think is difficult is subluxated cataracts, because that really gives a challenge, because entire surgical planning can get changed during the surgical planning as such. And you're looking into a various aspects of a subluxated lens. First thing comes to mind is what would be the etiology behind the subluxation. You are pretty safe if you have a history of trauma, because we know that entire jugular complex may not be degenerated or a disease. Therefore, surgery, whatever way we achieve, is going to last longer. The bag will retain its shape for a very, very long time. But you have a causes hereditary, where it is very difficult to manage the bag as such, or a comorbidity like hypermaturity, subsequent inflammation in the eye, or a pseudo-exfoliation. These are cases which are going to have ultimately the bag may not be retained in a way we desire. And we have seen many, many cases after 10 years, 20 years, they all get dislocated in the vitreous cavities. Therefore, if we have a traumatic subluxation, it is non-progressive and the surgery planning is simpler and you can achieve various things. These are few important things in the pre-op before we do surgery in these cases. We look after some of the important area which we know that should be taken care of, especially if there's a history of trauma. Do a good examination, look for a proper lens position. If the granules cannot be seen clearly, then we may have to do UVM to see the entire jugular capsular bag complex in these cases. Look for a degree of subluxation, look for a condition of granules, look for vitreous in the anterior chamber or in the angle areas. If possible, do a gonioscopy in these cases. Apart from that, the posterior segment assessment is very important in these cases of all cases of subluxation, because you may have a central macular pathology. There may be a macular hole. The visual analysis has to be done before surgery and properly counsel has to be done. This is the algorithm we always talk about, what should be done, how much subluxation can be managed without the bag fixation. I consider anything less than 5 or 6 clock hours, you may be able to do a good phaco in these cases and fix the bag. If it is less than 3 clock hours, then simple CTR would be manageable in these cases. So today I'm going to talk about those cases where phaco can be done simply without you have to fix the bag, because that's a different scenario as if you have to bag has to be fixed by various devices. So these are various intraoperative problems which you can face in these cases. One of the most significant will be a bag getting dialyzed and nucleus getting dropped in the vitreous cavity. So that is what we're going to prevent in these cases. You see, this is a case, I think this is around 10-year-old video of mine. You can see around 4 clock hours subluxation here. The idea would be to stabilize the bag before actually we do a nucleotomy in these cases. The iris hooks or lens hooks both can be used here. Here I'm using iris hooks in an area where the subluxation was there. But these are area the journals were intact, and the rexus has to be adequate size which can maintain the stress throughout. So subsequently, you can see here the nucleus rotation will be difficult. So I'm taking a piece of a nucleus so that there is a space created, and this space will allow the fluid to seep in and cause an internal hydrodelineation, so the subsequent nucleus management can be done effectively. I think something has gone wrong here. So something, nucleus can be managed effectively in these cases. You can see here, this is the one job I'm initiating here. If you see carefully, this rotation is difficult at this area. So once you see this type happening, take out this piece, the nucleus will now get tumbled into central area and rotation can be avoided. If you avoid the rotation, the stress to the granular complex is less and you can maintain the integrity of remaining granules in a right manner and subsequently complete the surgery in these cases. Before you take out the handpiece, always fill the bag with the dispersive viscoelastic. That will maintain the bag integrity, will not allow sudden collapse of antechamber, which can further damage the granules. So this is a classical teaching for all cases where you have weak granules or a weak capsule. In these cases, we have to maintain. Always do a bimanual aspiration, especially these areas where subluxations are there, because the pieces or a tax is difficult to remove from that area. Little tangential movement will help you. The CTR has been put here. Subsequently, we'll implant the IOL in these cases. This is second option, which I consider one of the good indication for using a femtosecond laser in a case of a subluxation. This gives the advantage of doing 3 important steps before opening the anterior chamber. One is capsulotomy, which is done effectively in most cases. Then the incision is done without opening, and the nucleotomy. So 3 important aspects: the nuclear fragmentation, capsulotomy, and incision has been done before actually open. Because once you make an incision, the subluxation can increase and things can become very difficult in these cases. Just to give you one example of how we do a case with subluxation, because this is the area of subluxation which is around 3 to 4 clock hours. The lens is shifted. I'm shifting my capsulotomy towards the area of largest available capsule. So this is the area of area. You can see here, there's a vitreous in the antechamber also. Despite that, capsulotomy is achieved. Because of vitreous, you can see a gel formation of laser hitting the vitreous here. Subsequently, nucleus fragmentation done and incision will be done effectively. So that's the advantage of a system where you can use effectively. But if you don't have a femtosecond laser also, you can do effective tamponade of an antechamber with dispersive viscoelastic in the area where vitreous may be there or where the subluxation would be there, apart from putting the hooks here. Now I'm removing the capsule here. I've stained the anterior capsule so that if there's a tag also, that can be taken care of. And you can see after I remove that, I'll be putting my iris hooks, which are little posteriorly placed. So they are parallel to the iris plane. Inject triamcinolone, identify the vitreous volume, do a vitrectomy before you do a nucleus management in these cases. That is a very important aspect of managing subluxation here. So once I do a complete vitrectomy, I'll do because of laser delineation, I don't require to rotate the nucleus, and nucleotomy can be completed without any hitch here. So this is a very important aspect of taking care of a vitreous before actually doing a nucleotomy in these cases. Separation will allow the bubbles to come out, and this will allow the nucleus getting released from the capsular cushion which is there in these cases. Subsequently, each fragment can be taken out, and effectively it can be emulsified in the bag without compromising the peripheral granular complex in these cases. I'm highlighting that because the bag fixation is very important. Sometimes you may have to insert the CTR before you do actually these procedure, depending on amount of degree of subluxation in these cases. This is the rotation of a superior piece, and just pulling to a center, you can complete this entire emulsification effectively. The parameters has to be moderate. Bottle height is normally IOP of mine is 55. Here I put 46. Therefore, the management of subluxated case will be more effective in these cases rather than keeping the higher pressure in these cases and increasing the aspiration and vacuum in these cases. After I complete my nuclear emulsification, same procedure, I'll fill the bag with the dispersive viscoelastic. before I initiate the aspiration of cortex or taking out my handpiece subsequently. And this is going to safeguard the entire procedure. You can put CTR subsequently and implant the lens in these cases, as you saw in a previous case also. This is the post-op result of same patient, absolutely clear cornea, stable back and IOL in place and good vision. And the technique, you can see in IGO video gallery, the entire technique is visible there. So I would summarize, if you have a subluxated cataract, especially traumatic variety, you can do a good phaco in these cases without fearing to increase the general damage in these cases. So any subluxation less than 5 clock hours, you can effectively do phaco, may not require a back fixation. Make sure that cases where you have a difficulty in the intraoperatively back get dialyzed, rotation is difficult, nucleus is tilting, it's better to shift to a manual surgery in those cases than trying to do a complete phaco in these cases. Thank you, and these are a highlight of our post-op management, which is so important for all cases, more important for traumatic subluxury cases.
Thank you,
Thank you
Professor
again.
Titiyal. This was a very difficult topic and a difficult scenario, but you made it very simple with a lot of clarity. So thank you so very much. I think we move on to this very familiar situations of hard nuclei and cataracts, and there is no better person than Maipal here to talk on it. Thank you. Maipal.
Hello. Yeah. Thank you very much, Abe, and thank you, Dr. Titiyal, for having me in this course. Always a pleasure being here. I'll be talking about phacoemulsification in hard cataracts. And hard cataracts, soft cataracts, subluxated polars, etc., they remain challenges even for the most experienced surgeon. So when you are looking at a hard cataract, essentially what I'll wish to say is that one needs to diagnose a hard cataract pre-operatively. It shouldn't be that you go on the table and you feel that there is something that I need to do and it's a hard cataract. Now, there are several studies that have been done. This is the famous Swedish capsule rupture study, in which it has been shown that white and brunescent and hard cataracts are associated with increased risk of capsular complications. It happens to the best of us. Obviously, the machines and the techniques have improved significantly, and this is what I am going to tell as to what should be the techniques, etc., which can reduce the incidence of complications, specifically posterior capsular rupture and corneal problems. Now, the first and the foremost important thing is that pre-operatively, as I said in the OPD, before you are taking the patient for surgery, there are certain pre-operative considerations that you need to have. And these considerations would be pupillary dilatation. When you are looking at pupillary dilatation, what is very, very important is that you should also take the history of a patient being on tamsulosin, because nowadays hard cataract has been sitting for long, so these are aged patients, and they are the urologists are using tamsulosin very, very often. Then it is very important to look at the state of corneal endothelium. It's a standard of care for us that we do a specular microscopy. If you don't have, you do a good specular reflection on the slit lamp to see the corneal endothelium. You need to look at the zonular integrity, because obviously you know that there is going to be some more manipulation. The morphology of the cataract needs to be studied, and if possible, the posterior segment evaluation should be done. Now, what are the challenges that you have in a hard cataract? There are a couple of challenges. First is the compromised visibility, and that is because when you are doing the procedure, there could be a absence of red reflex. This could be also compromised visibility because of the milky fluid. When you are doing the capsulorhexis, there could be a problem because often these hard cataracts have some fibrosis which should be associated, and you may have difficulty in doing a capsulotomy. Then when you look at these hard cataracts, they tend to be sitting there for long and they could be swollen, so you have less space for surgical manipulation. Hydrodissection, hydrodelination could be difficult, but I think this is the bugbear where you have leathery fibers which may be difficult to separate completely, and that is the problem which I'll be discussing. Now, when you are looking at the nucleus essentially, the anatomy is that it is the center which is the thickest in the nucleus. and the leathery fibers go and interdigitate right at the bottom. So it is very, very important for you to break the backbone or the spine of the nucleus, which is of importance. Now, how you break or how you do the nucleotomy could be that you could do a trench, you could do a direct splitting, or you could do a chopping. Now, when you are done a trench, the important thing is that this is how the forces have to work, and the trench needs to be pretty deep. You need to be about 90% thickness of the nucleus in the center. The periphery will break more easily, but it is the center that needs to be broken. Now, if you have a trench which is not deep, you can see that the vector forces are working like this. But if the trench is deep and you have the two instruments, then the forces work in this direction, and therefore that is how the backbone will be cracked. So the important key message that I want to give you is that the depth of the trench is very, very important, and the placements of the two instruments by which you are going to crack it or split it, that needs to be down below so that you are able to do this. Nuclear emulsification, chopping techniques, you can do divide, conquer, primary, stop and chop, crater. I won't, that's a choice of the surgeon. My personal choice is a primary chop. And modifications of the primary chop for rock hard cataracts could be that you could make a crater in the center, or sculpt and then chop, or you can drill a hole and then chop. So these modifications allow safer in the bag chopping and emulsification. So that is something very, very important. So this is, I'll show you a video which is maybe a decade old, and a video that we have done now. So this, you can see, is again on a good signature. This was the first signature machine. Now you have Signature Pro and Veritas, but you can see that I made a trench, and then I have gone deep in, and now you see that I am separating the fibers. So what is very, very important is, look here, crack in the midline. Can you see this crack in the midline? Until, of course, you are able to crack in the midline, these things will interdigitate and come out together. Now again, I have rotated it 180 degree, and you can see again that I am trying to get this split. Can you see this? Just watch. Once you have got this split right into the center, then only try to remove the fragments. Understood? Now you can see there is no epinucleus cushion. So you need to put viscoelastic, viscoat that we have put. And again, you can see I'm chopping from the center. Hold it deep, bury deep, go to 90% of the depth, 80-90%, and again wait till you have the chopper separate the nucleus right till the backbone of the nucleus. So that is something very, very, look at the color of the nucleus. You can see it's a dark brown black cataract. And again, you can use the chopper to hold it and feed it into the nucleus into the probe. Now, mind you, you can see the vacuum going up to 500. This is a 19 gauge needle. I normally don't use thinner needles because they tend to get clogged with the nuclear material which is there. And you can see the rock stability even at such high aspiration and such high vacuum. So again, you can see, look at the depth. You need to be careful that we are away from the endothelium, as also what we have to see is that there is no epinuclear cushion. So you have to maintain a balance, and you can see that this is now the pretty much the end of the nucleus, and that's the IA, and you go ahead. Now, this was a case, I would say one of the hardest cases that I have done vis-a-vis on femto. So my associate said that we should go ahead and do an SICS. I don't know how to do an SICS, but I said, let me just try the phacoemulsification. So you can see this is a pre-cut nucleus. We pass the femto incisions 3 times. We make a larger capsular excess. So one important thing in hard cataracts is that do not make a small capsular excess, because you will not be able to take out the nuclear fragments in a small capsular excess. So this is a much harder nucleus. So we have made a bigger, which is a 5.2 on femto, which actually would become about 5.5. Now again, you can see I have sculpted, though there is a pre-cut. I'll just show you that there is a pre-cut which happens even in black cataract. It's the white cataract. Just, can you see these bubbles that came out? So what do these bubbles show? These bubbles showed that the femto laser has been able to penetrate, and again you can see that this is a black cataract, blacker than what I showed you earlier, and we were able to split it in the center. So you can see that the center one has been able to split, and you can see again that in this particular case you can again see that it is more black than the one that I showed you. I have brought out the fragment into the pupillary plane, and you can see that again, because it has been femto chopped before, we are able to get the break of the nuclear fragment much easier. And again, we are using a very high vacuum 19 gauge needle that we are using, and we are able to get the separation of the pieces. So you can see again, can you see the color of the nucleus? So we have again been able to separate. Essentially, rock solid chamber, good machine. Know the settings of the machine. It is not that you are using a lower end machine and you take it to 500 vacuum and you get a flow rate of 45, 50. You're going to have a surge and you are going to have problems. It is depending on the machines. You have to have the proper chopping. You have to break the backbone of the nucleus, which is very important. Stressing again and again, whether you do a crater, whether you do a sculpt, whether you do a trench, it does not matter. But till you are able to break the nucleus right in the center, you will not be able to do justice. And you can see that finally the entire nucleus is being devoured by the phaco, and you can see this is a good capsular access that we are having. So intraoperatively, difficult situations during nuclear repulsification have to be looked at, but incomplete separation of nuclear fragments following chopping with the leathery fibers being tenacious is what makes it much more difficult. That is something very important. An absence of epinuclear cushion for the protection of posterior capsule is important, and you need to use the parameters which you are comfortable with. In case you have a PCT, please do not continue fishing about. You need to detect it early and optimal management. If you have to close the incision and leave it, thank you. Then under those circumstances, it is very good. You can have your posterior segment person go ahead. Dispersive OVD, which is chondroitin sulfate, can tamponade a posterior capsular tear, and anterior vitrectomy could be used for vitreous prolapse cases. Now, post-operatively, you are working with a prolonged surgical time, so there would be an increased risk of AC inflammation and cystoid macular edema. So intensive topical steroids are needed. Cycloplegics are something that I give in such hard cases. Even if I do them under block, I normally do not do under topical, because if you have to convert, and I give a subconj atropine in these cases so that the inflammation can be reduced. And to prevent CME, you need to have the NSAID continued for about 3 weeks. So I think that is the important thing. IOP needs to be monitored because you have used a lot of chondroitin sulfate to protect the endothelium. So friends, hard cataract is a difficult nut to crack, but if you follow the proper techniques and you take the help of good machines, good technology, which could be good machines, or if you could have a femto laser, I think dealing with a hard cataract is something that can be done easily with a phacoemulsification. Thank you very much for your kind attention.
Thank you, Dr. Mahipal, sir. And we know that hard cataracts can be very difficult to manage sometimes, but looking into a basic aspect of managing cataract, if you look into a hardness, do a proper technique, safeguard the endothelium, most often the results are very gratifying in these cases also. And femtosecond laser would definitely be advantageous in these cases also. If you can at least make a nucleus softer, then subsequent energy use will be less and damage to the endothelium, and the surrounding uveal tissue will be also less. So effectively look into not only intraoperative advantage, it has an advantage in the post-op period also, where inflammation will be less in these cases. Thank you, sir, for highlighting all these important tips. Now we invite Dr. Abhay Vasavada, who's going to talk to us in his most favorite talk on posterior polar cataract. How to manage these cases effectively so that we come out with all the difficulties can be taken care of on the table. Dr. Abhay, please.
Thank you. This is my financial interest, but has no relevance in this presentation. And I just want to make sure that we understand the posterior polar cataract. This is a kind of a posterior polar cataract which late Dr. Daljeet Singh described as onion appearance and bullseye and whatever. It is distinctly different from posterior subcapsular plaque cataract. So you need to make sure it is a posterior polar. And I recognize the contribution of Dr. Osher, and it's a great pleasure to recognize Professor Jeewan Titiyal's and Manpreet Kaur's contribution on the subject in recent years on various aspects of diagnosing and dealing with this posterior polar cataract. I think if I had to number one pearl, I would say avoid the hydraulic rupture of this thin, fragile capsule, and that happens because the fluid is trapped in that critical compartment. So avoid the rapid buildup of the hydraulic pressure and therefore hydraulic rupture, and it's common sense that you will not do this cortico-cleaving hydrodissection or subcapsular hydrodissection. Second thing, it will be prudent to create a protective cushion effect to that fragile capsule, and if you can do that, it's not 100% necessity, but it's a good idea, and I recommend that. But mind you, the conventional hydrodissection has served the purpose very well, but sometimes there can be inadvertent fluid seepage into subcapsular plane and therefore hydrorupture. So to make sure that doesn't happen, we, with the help of Dr. Shetal Raj and other colleagues, developed a technique what we named inside-out delineation, where the fluid is injected in the wall of the core of the material of the lens, and therefore chances of subcapsular hydrorupture will be less. This is the clinical example. Create a space, and a typical posterior polar, it's very soft cataract in a patient of 30s and 40s, and it's very easy to produce this demarcation and appropriate depth of mechanical cushion effect. Third is to adhere to the principles of closed chamber technique, and therefore anything you do should not make this capsule diaphragm bulge forward. And therefore, when you exit the instrument out of the eye, inject OVD. I prefer viscoat, a dispersive viscoelastic, but whatever. Make sure that the contours are maintained. And this is very important, that when you have removed the nucleus, now you have an epinucleus, and you have two compartments, one in front of the epinucleus, anterior chamber, and one behind that critical space. So you detach the epinucleus a little bit, and idea is to create the communication now between the posterior critical space behind the epinucleus and the posterior capsule and anterior chamber. So the fluid shifts in, and then the fluid is not trapped there, and there is, now you can do subcapsular hydrodissection if you want to into the subincisional area for thicker epinucleus. So create a communication between these two compartments. And femtodelineation, and I use femto being used in dense cataract, but Jeewan Titiyal would vow that femtodelineation or any other techniques of flex really makes it more controlled procedure, and there are various ways of using this technology. And in our hands, we reported 32% at one time, then reduced to 8% with inside out, and now it is about 4% with this flex technique. And that's because the cushion effect is created well and no need to rotate. So there are, I recognize Professor Titiyal's presentation here with Manpreet here, but this is what we typically do. I don't want to go in details, but you can shell out these, I'm not able to handle this here, but you can bring out those demarcated, femto-demarcated fragments to the tip, and then make it very easy and user-friendly to the, I'm not able to move this forward for some reasons, that's okay. And then when it comes to the subincisional, the same procedure, shelling out, and it is so easy because it's laser cut, very sharp division, and it's very easy without rotation. Keep the phaco probe right in the middle, do not chase and rotate the nucleus, and And it's possible. Now is the time to bring that communication business, detach the epinucleus a little bit so that the fluid is equally distributed in both compartments. And the bottle height should not be very high, and flow rate modest, 20 cc per minute, maybe 25, but not very high. We want a good control on it. And then you can avoid that thing happening there. Now, at this time, if it doesn't come, it's quite okay to do subcapsular hydrodissection because fluid won't be trapped there. So don't make an issue of these if it doesn't come. Always do subcapsular hydrodissection, but remember, inject viscoat or something like that. And with the bimanual, it's not difficult to produce that total removal of the cortex here. Once again, swap the instruments there and perform that. Now, the best part of these principles that we just went through is that you can deal with any degree of density or any integrity of the posterior capsule. These are the examples where these denser fragments were fed into the phaco tip without rotating, and be well, notice it's facing down. I'm not worried about the surge because of the appropriate flow rate and also the machinery that we have. So 20 cc flow rate will not attract the posterior capsule. Once again, another example of these denser fragments. With the flex, it's a little easier because they are already pre-grooved to some extent, but even if they are not, inside-out delineation will be enough, and you can see these denser fragments coming to the phaco tip and being fed well with 40 IOP. That means about 52 centimeter bottle height and 18 to 20 cc per minute flow rate, and appropriate power, which is here at about 40 or 50, and using an interrupted, which is my personal choice, but whatever mode you want, and take this out at your time. Notice how slowly that we are doing. We need to be very patient about it, be conscious of the chamber stability, and if you can lower the flow rate and vacuum if you are scared when the posterior capsule keeps glaring at you. So take your time, but make sure that you remove it at the right plane. I'm keeping my bevel facing sideways and also to the posterior capsule because I want to avoid the impact on the endothelium. So this is one more very good case, bilateral posterior cataract with both eyes pre-existing defect. And that's where the flex or the intraoperative OCT or imaging technology will help. We could recognize, we could see that in the slit lamp also, but sometimes with the density, the cataract, we may not be able to visualize. So all this imaging technology will make you prepared, and you will anticipate appropriate thing. And this is on the table, the same eye, you can see the posterior capsule defect already present in front, behind the posterior capsule, posterior polar defect. So once again, if you do not have a flex, doesn't matter. You can carry out very controlled inside-out delineation or whatever delineation you want to take, but make sure that you protect the exposed vitreous phase. The aim is to prevent the vitreous prolapse here, and therefore mechanical cushion effect of a decent depth is important. You can do that equally well with manual techniques of delineation, but flex will make it a little easier. Now, once again, I am trying to remove that nucleus bottom part, and notice my IOP is 20, that means 30 centimeter bottle height, 20 millimeter mercury pressure, and flow rate is 16 cc per minute. Sometimes I go to 12 cc per minute with phaco probe. You can't go lower than 12 cc, but you use as low parameters as you can, and detach it and establish the communication so that the fluid will cover it. Now I raise the bottle height from 20 to 30, and sometimes I go to 40 because now I have a fluid pressure sitting on that exposed vitreous. I'm not worried about unequal hydraulic pressure because it's all communicated well, and that posterior polar stuff is coming out, as you can see. And bimanual technique, once again, really is a great help maintaining the contour and not utilizing the valve effect of the main incision. So that's protected. So far we are lucky, but anytime vitreous can prolapse. So because of the, notice the IOP has gone down to 50, that is 64 centimeter bottle height, because now I want a good pressure on the exposed vitreous face, and I was lucky that it went on okay. Now, I would prefer a 3-piece IOL when the capsule is open, posterior capsule is open, and you can utilize a 3-piece, sometimes capturing it through this, or putting the haptic in the ciliary sulcus and having optic at a different plane. So you can do that. I'm utilizing that pre-existing defect as to capture. So I'm pressing the optic, nudging it opposite direction, and then pressing it posteriorly. So the optic has gone behind the posterior capsule, in front of the antivitreous face, and the haptics are at the ciliary sulcus. So you can utilize various combinations, but make sure whenever the posterior capsule ruptures or is open, at the end of the surgery, I've taken the suture, the main incision, to make sure, is there any vitreous? Well, I didn't have a vitreous, but I had kept vitractor open in anticipation. I didn't have to use it. So this was an opportunity for me to use to remove the, aspirate the viscoelastic. There was no vitreous. Just because I had vitrectomy opened up, I had to justify its use. This is what it looked later on down the line, post-operatively, and monitor peripheral retina and so on, and monitor the stability, whatever imaging you have. And lastly, the pearl 6 is the most important pearl. Pre-operatively, please tell the patient, not only the patient, but bring the family members. One second counseling, we do 2 counseling settings, one with the patient and whoever has come, and we say, whoever else is with you, bring them next time, and tell them all the eventuality. But finally, remember, posterior polar cataract is not over until you remove the speculum. So this is an example. My nurses were packing up, and they were very happy that I could do posterior polar without any problem. And look what happened. If you are not very careful, or if you are very aggressive, this can happen. Now, we had a dilemma what to do. We decided not to do anything and leave it because there was no vitreous prolapse. And it worked well, luckily for us. But the point is that posterior polar is not over until it's really over. So to sum up, these are the pearls I learned from the stalwarts sitting on the dais, Dr. Osher and many others. So keep in mind, and good luck when you have this kind of cases next time. Thank you so very much.
Thank you, Abhay. Such a wonderful teaching on the posterior polar cataract. And the videos were so clear, so transparent to see every bit of fibers also. And your teaching has been, I think, it has gone to everybody to how to perform effective phaco in these cases of posterior polar without the capsular opening or a capsular opening or intraop difficulties. Beautifully shown. Thank you again. I would like to invite now Dr. Partha Biswas, the chairman of our scientific committee, AIOS, to give us his own tricks, tips. Another difficult situation of doing phaco in post-refractive surgery patients. Not only for doing phaco, for getting a good outcomes in terms of a good calculation of IOL power and the effective counseling which Abhay talked about, not only to the patient, to the relatives also. All yours, Dr. Partha.
Thank you very much, sir, for inviting me to this course, a very, very valuable course that you have year after year. And post-refractive surgery phacoemulsification is something that we need to talk about, because though it might be a rare possibility in a crowded OT, but still when this possibility comes, then one has to be absolutely on the toes. So how do we approach a patient of post-refractive surgery phacoemulsification? So what are the challenges? And the unique challenge to the cataract surgeon is because this patient is a demanding patient. He always has been without glasses, and at his presbyopic age might have put on just the reading glasses, and thereby he needs that vision free of glasses even after his cataract surgery. So there are certain amount of unrealistic expectations, low accuracy of the current biometry formula, which are becoming better and better every day, but nothing is foolproof. And therefore, the refractive surprise is the most important thing, and the traditional formulae lose accuracy because these patients can end up with post-operative hyperopia. And if that happens, then it's a huge difficulty. Post-hyperopic refractive surgery patients can end up with post-operative myopia. So what are the sources of error? And it's the keratometry, which the assumption of the spherocylinder cornea leads to an overestimation of 15 to 25%. So the relation between the anterior and the posterior cornea is altered, and the assumption of the refractive index of 1.3375 actually becomes fallacious. So it's an error in the formula, and thereby after a myopic KRS, these formula predict false shallow ACD, leading to an anterior ELP, and thus an overestimation of the intraocular lens power, causing the post-operative hyperopic surprise. So the formula which are supposed to be used in these patients, the historical method is a matter of history now because we have better things, and again, which we do not rely upon so much. The ASCRS online formula is freely accessible on the website, which allows the input of the data available with or without the preoperative data. And also the multiple formula that are available to calculate the IOL power, and an average of all the formula is also displayed. So the tomography is also helpful in analyzing the anterior as well as the posterior corneal curvature. And the intraoperative aphakic calculation is one aspect that I need to stress upon, and the simple on-table retinoscopy after extraction of the cataractous lens can be a very, very accurate method of choosing the right lens. The intraoperative aphakic aberrometry may also be used, but it is expensive. Limitations include alteration of IOP, patient fixation, pressure of the speculum. The ALP prediction is still not accurate. But again, I will stress the simple on-table retinoscopy is something that I trust even today by my best optometrist who comes in and does the retinoscopy during the surgery. And I'll suggest that all of us follow this method as a final cross-check, and then that post-operative surprise will not happen. The role of pre-operative counseling is even more than what Dr. Abhay Vasavada said for his posterior polar cataracts. Here, the counseling has to be intense, has to be persuasive, has to be elaborate, and has to be done by the surgeon himself. And here, the realistic expectation regarding the spectacle independence must be given. The intraocular lenses may not be, the presbyopia correcting intraocular lenses might not be the right choice for these patients and must be explained in detail. Also, the residual astigmatism. The post-RK phacoemulsification, and here where there are more than 8 incisions. So here the incision that you have to make is a scleral incision, because if it is a corneal incision, these incisions of the RK might open up, and then you have a very difficult proposition. The phaco has to be performed with low parameters, and the patient counseling regarding the irregular astigmatism is very important. Here is a case where the RK incision opened up, and these have to be sutured meticulously. Let's talk about this mystery case to drive home a very important point. This lady presented to us with a 2-grade cataract, and we planned phaco plus IOL. All biometric calculations were done, and then she comes back without her husband to tell that some 19 years ago, she had some surgery done to remove her glasses. So the pentacam then was done, and it became a very, very important tool, and we could see that there was an evidence of refractive, laser refractive surgery that was done. So we evaluated, and we took on the pentacam readings, the flattest of the K readings, and calculated. We calculated, but on the table retinoscopy provide us the final biometry or the final IL power calculation, and we implanted 15. We implanted a 15 diopter lens. The ASCRS online calculator gave us a 12 diopter, but we did implant the 15 diopter, and this was the post-operative result. So with this post-operative result, had we implanted the 12 diopter lens, we would have definitely beyond the error. So again, to stress upon the fact that the on-table retinoscopy is very important. The post-ICL phacoemulsification, the ICL is a very thin structure, and there has to be no evidence of removing the biometry, any deviation from the biometric calculation that you would do for a normal patient. Am I the last speaker, sir? Can I? Okay, I'll just take 2 minutes then. So this is a case which I just wanted to show you how complicated it can be. And here, this is a case which went on after laser refractive surgery. The patient had a retina detachment. The retina detachment was resolved by the retina surgeon. But in 3 months' time, the patient lost vision. And the vision was lost because of this intermission cataract. This was a patient who had undergone a phakic eye, an ICL, and after the ICL, the retina detachment occurred. The post-operative to the retina detachment, this was the intermission cataract. So the removal of the ICL is being done, which is not so difficult, and a hand-over-hand technique is being applied for this patient. The ICL comes out quite smoothly in such patients, but it has to be done very well. So we put in trypan blue for this patient, but this is an intermission cataract, and you would have noted that there was some synechia in this cataract. So I'm going to have trouble here, and as I try and do off the capsular axis, the capsular axis runs out. And it runs out not in one place, but in 2 places it runs out. So we have an open bag here, and the pupil is crowding. And why did this intermission cataract occur in the first place? There was a lens touch by my retina colleague, and that is the reason why it had occurred. You can see the plaque sitting over there. So we placed in a 3-piece lens in this patient, put it in. We do not know whether it went into the sulcus or half into the sulcus and half into the bag. But then what we had to do is to do an opening in that plaque. And it's very important to limit the opening in the plaque, and we did it with the MVR blade going in, and then with the vitrector carving out a small area through which the visual axis could be assessed. And so after this, the patient, of course, did not gain 6/6 vision, but had a good vision of about 6/24 and N12. So just to show that these situations might arise not every day, but it can happen, and when it does happen, then things have to be taken in the course of the light of that particular patient, with all the importance given to the refractive analysis and the workup, as well as the surgical technique and the pre and the post-operative counseling. Thank you very much for your patient hearing.
Thank you very much, Dr. Partha, for highlighting all the aspects of doing cataract surgery, post-refractive surgery, let it be the old generation radial keratotomies or ICLs or laser surgeries, where it is demand from not only from our side, from patient and parties to have an exceptionally better vision than any other group of cases, because they have undergone refractive procedure in their younger days. And cataract surgery, I believe, is surgery where you can get a absolutely fantastic vision after removal of cataract. We had a terrific session covering all the aspects of a difficult situation as well as a simple answers for these cases. I would take, we have few minutes here. I request each one of the instructors to give us some one-line important tips to our audience sitting here. Start with Dr. Abhay Basavada.
Are you allowing questions or it is American Academy of Ophthalmology? No questions.
Sir, you are welcome, sir. You can ask question.
My name is KPS Malik. Sir, Vasavda sir, are we not overdiagnosing the posterior cataract?
Yes, I told, that's why my first line was that make sure that you're dealing with the right condition. Most of the time, when I discuss with colleagues and I see the videos and slit lamp photographs, they are actually posterior subcapsular plaque cataract. They are not posterior polar cataract.
Yes, they are not.
Posterior polar cataract is a distinct entity, and as I said, Dr. Daljit Singh was the first one in India to describe it as the onion appearance,
I know
which
that,
is known
but
as the bullseye.
Most of them are cleared out.
Unless you have that appearance, and typically in a patient who is in his 30s or 40s, it's a developmental defect.
Yeah.
Genes have been identified. 3 genes have been identified for that particular posterior polar cataract. This is the entity we are talking. Most of the time, we loosely refer posterior polar cataract because it's located in the back of the lens. That's not posterior polar cataract.
Little bit more query.
Right.
The dehiscence you showed, I have never seen this big dehiscence in posterior cataract.
I have 5 of such cases, sir, over the years.
Thank you.
Thank you, sir. I think, as you rightly pointed out, and Dr. Abhay also talked about, initial examination of all these cases are very important to differentiate cases where you'll have the posterior capsular adhesions or a posterior capsular pre-existing defect in these cases. Grossly, people like to put them in a posterior polar category because sometimes you do have problems, complications. So you're safeguarding yourself also in these cases. No harm in overdiagnosing posterior polar cataract as such. Yeah, Dr. Ram.
Single tip, my topic was on intermission cataract. I think whatever way you do it, make sure that the intralenticular pressure is less than the intraocular pressure or the anterior chamber pressure. Whether you do it by evacuating lens material from the bag or use cohesive viscoelastic to depress the capsule. As far as you have a flat capsule, the tendency for the rexus to run off is less.
I think I appreciate the technique, especially we talk about 2-stage capsular rexus in these cases, which gives the opportunity to decrease the intralenticular pressure. And subsequently, as you nicely showed, the aspiration of a hydrated cortex and decreasing the pressure, then doing a rexus enlargement to give access to emulsification in a right manner. Dr. Mahipal sir, would you like to say one sentence to your hard cataract?
Well, as you summed it up earlier, all that I'll wish to say about the hard cataract is that hard cataract is something that we can manage with the proper technique and the proper instrumentations. You need to know your instrument. Important thing is know the dials of your phaco. Because this needs a high vacuum and a high aspiration and a larger bore, the lumen of the tip needs to be larger. So that is something very, very important. And the last thing which I again re-emphasize is that you have to break the entire lens in its totality right up to the bottom or the backbone. Without doing that, the interdigitating leathery fibers cause problem. Thank you.
Thank you, sir. I think we are right on the time. I would definitely like to thank the delegates being here, and their participation is actually the incentive for people to come again and again and give these talks which we have been giving for so many years. And it's not that you are the only people learning. We all always learn from each other, and your questions, your answers are always welcome to us. You can always contact us in all our emails. We can answer your queries. And thank you again. I'd like to thank all my instructors. Because of them only this course is being done in AIOS for so many years. Thank you again, all of you.
Thank you.